There is a number, a small two-part number that appears on a screen, gets circled in a chart, earns a nod of approval from a physician, and sends a patient home feeling reassured. And for millions of people over 60, that number is quietly, invisibly doing the wrong thing inside their body, not because it is too high, because it has been pushed too low for arteries that are no longer what they were at 45, too low for a brain that depends on adequate pressure to stay clear and sharp, too low for kidneys that filter your entire blood volume dozens of times a day and require real, sustained pressure to do it safely. And the cruelest part of this story is that you cannot feel it happening. You just feel a little foggy in the mornings, a little unsteady when you stand, a little less certain on the stairs than you used to be. And because those feelings arrive gradually, because they come on so slowly and so quietly, most people over 60 do exactly what the people around them expect them to do. They accept it. They call it aging. They hold the railing and say nothing. I want you to hold that image in your mind for a moment, because what I am about to share with you today may be the most important medical conversation you have had in years. Not because it is frightening, because it is clarifying. And clarity, in medicine after 60, is one of the most powerful protective tools that exists. My name is Dr. Sandrine. I have spent the better part of 2 decades working with adults over 60, listening to their bodies, reading their histories, and asking the questions that a 7-minute appointment simply does not have room for. And the question I want to ask you today is one that most physicians never get to, not because they do not care, but because the system moves too fast and the silence around this particular subject runs too deep. The question is this: the blood pressure target printed on your prescription, the number your doctor is aiming for when they adjust your medication, was it calculated for your body? For your arteries, at your age, with the specific vascular changes that happen to every human being who lives past 60? Or was it calculated for a body 20 years younger than yours, and then simply handed across the decades as though biology stays still? That question deserves a real answer. And today, I am going to give you one. Let us begin at the foundation, because everything that follows builds on this single essential biological truth. The standard that has governed blood pressure medicine for decades, the one that your doctor trained on, the one that informs most prescriptions written today for patients of every age, was not born from studies of older adults. It emerged primarily from research conducted in middle-aged populations, people in their 40s and 50s, with the cardiovascular physiology that 40s and 50s produce. Elastic, responsive arteries. A renal system operating at full efficiency. A brain receiving consistent pressure-stable blood flow through vessels that can expand and contract with each heartbeat. That research was rigorous. The conclusions were valid for the population studied. And then, as medicine so often does, those conclusions were applied broadly, across age groups, across decades of biological change, as though the cardiovascular system of a 72-year-old is simply a slightly older version of the one at 48. It is not. And understanding why it is not is the beginning of everything. After 60, the arteries change. Not as a disease process, not necessarily as the result of poor lifestyle choices, but as the documented universal physiology of vascular aging. Collagen accumulates in the walls of the vessels. Calcium deposits form gradually, layer by layer. The smooth, elastic lining that could stretch to absorb the surge of blood pushed out with each heartbeat and then recoil to maintain pressure between beats becomes progressively less flexible. Think of a brand new garden hose, one that bends easily, absorbs water pressure smoothly, and springs back to shape when you release it. Now think of that same hose after decades in the garden. Slightly stiff, slightly rigid, still functional, but the way it handles pressure has changed fundamentally. That is an approximation of what happens to the arterial system after 60, not broken, not diseased in the conventional sense, but operating under different mechanical laws than it did 2 decades earlier. And here is where the blood pressure conversation becomes genuinely complicated and genuinely important. When the arteries are elastic, as they are in younger adults, they act as a biological buffer for the cardiovascular system. The large central artery, the aorta, expands with each heartbeat to absorb the surge of blood and then recoils between beats to sustain the pressure that keeps blood flowing to every organ in the body during that resting phase. The systolic pressure, the top number, reflects the surge. The diastolic pressure, the bottom number, reflects the sustained flow between beats. That recoil, that elastic return, is what maintains your diastolic reading. When arterial stiffness progresses, that recoil diminishes. The aorta no longer springs back with the same force. Systolic pressure tends to rise because the rigid walls cannot absorb and buffer the surge. Diastolic pressure tends to fall because there is less elastic return to sustain pressure between beats. The gap between the two numbers, what physicians call pulse pressure, widens. And a widening pulse pressure is one of the most reliable biological markers of vascular aging that exists. It tells a physician, if they take the time to look, that the arteries of this patient are stiffer than those of a younger person, and that the blood pressure targets appropriate for younger, more elastic vessels may create problems in this one. Now bring medication into this picture. Most antihypertensive medications, the drugs most commonly prescribed to manage high blood pressure, work primarily by reducing systolic pressure. That is their mechanism. That is what they were designed to do. And in a younger patient with genuinely elevated pressure and elastic arteries, driving systolic pressure downward is protective. The evidence for this in the right population, at the right age, is solid. I do not question it. But in a patient over 60, with already stiffening arteries and naturally declining diastolic pressure, applying the same aggressive reduction in systolic pressure can push the bottom number into a range where something significant and damaging begins to occur, something that rarely gets named or explained at the appointment where the prescription is adjusted. The heart muscle itself begins to underperfuse. Let me explain why this matters so profoundly. The coronary arteries, the vessels that supply blood to the heart muscle itself, receive the majority of their blood flow not during the systolic phase, not when the heart is contracting and pushing blood outward, but during diastole, the resting phase between beats. When the heart relaxes and refills, the coronary arteries, which are compressed during contraction, open up and receive their blood supply. The pressure that drives that supply is the diastolic pressure, the bottom number. The one that in a stiffened arterial system is already under natural downward pressure from reduced elastic recoil, and the one that aggressive medication can push further downward still. When diastolic pressure falls below a certain threshold in an older adult with arterial stiffness, the heart muscle begins to receive less blood during its own resting phase. The deprivation is not dramatic and is not acute in the way a blocked artery causes a heart attack. It is gradual, it is cumulative, and it is silent. The patient feels nothing specific that they can point to. They feel generally less well, perhaps a little more tired than usual, perhaps a little more short of breath on exertion, things they would attribute to age before they would attribute them to a diastolic blood pressure that has been pushed 5 or 10 points below the threshold their particular cardiovascular system can safely tolerate. This is the phenomenon physicians call the J-curve effect. When researchers plot cardiovascular risk against blood pressure levels on a graph, the expectation is a straight line: lower pressure, lower risk. A clean, descending relationship. But in older adults, what the data actually shows is a curve shaped like the letter J. Risk falls as dangerously high pressure comes down. That is the expected beneficial effect of treatment. But below a certain point, the curve bends. Risk begins to climb again. Not precipitously, not as a cliff edge, but measurably, reproducibly, across multiple large studies conducted in older patient populations. The bottom of the J, the inflection point where risk is lowest, is not at 120/80 for every person over 60. For many, it is higher, and identifying where that inflection sits for a specific individual, rather than applying a population average, is what genuinely personalized medicine in blood pressure management looks like. I want to tell you about a patient I will call Emile, 73 years old. A man who had spent his professional life as a civil engineer, precise by nature, meticulous about his health records, the kind of patient who brought a printed spreadsheet of his home blood pressure readings to every appointment. He had been managing hypertension for 11 years. He followed every instruction diligently. When his doctor added a second antihypertensive to bring his systolic from 144 down toward the 130 target, Emil complied without question. His readings improved by the metric his prescription was chasing. 6 weeks later, sitting at 121/68, his chart looked excellent. Emil came to see me not because he felt dramatically unwell. He came because he felt quietly wrong in a way he could not articulate clearly enough to bring to his regular physician. He was foggy in the mornings in a way that was new. His thinking, always sharp and precise, felt like it was arriving through gauze. He had stopped his evening walks because twice he had felt dizzy enough upon standing to make him uncertain about being outside alone. His wife had noticed he was holding furniture as he moved through the house in the morning. He thought perhaps he was coming down with something. He thought perhaps it was just age catching up. It was not age, and it was not an approaching illness. It was orthostatic hypotension, running silently inside a body whose cardiovascular system could not safely sustain the blood pressure target it had been given. When I measured Emil's blood pressure lying flat and then measured it again the moment he stood, the systolic dropped 26 points in under a minute. His brain, in those seconds of transition from lying to standing, was receiving meaningfully less blood than it needed to maintain clear function and stable balance. Every time he rose from a chair, from bed, from the toilet, from any seated or reclining position, his brain was briefly deprived. Not enough to cause a stroke. Enough to create the fog. Enough to make his legs unreliable. Enough to make him a fall risk in his own home. A man who had walked 5 kilometers every evening for 15 years. That lying to standing measurement, which took less than 3 minutes, revealed something that 11 years of sitting position-only readings had never shown and could never show. And the reason it had never been done is simply this. It requires the extra minutes, and in a routine appointment already compressed by a crowded schedule, those minutes are usually the first to disappear. We worked with his own physician to adjust his medication carefully, shifting his target to a range that reflected his actual arterial biology rather than the population average for adults 20 years younger. Within 3 weeks, the fog that Emil had begun accepting as his new normal was clearing. Within 6 weeks, he was walking again. At his 4-month follow-up, he brought his spreadsheet, as always, and the numbers on it told a story of a body functioning more safely, even though the blood pressure readings were higher than what his original prescription was targeting. He said something I have thought about many times since. He said, "I trusted the machine more than I trusted myself. When the number looked good, I assumed I was fine. I wish someone had told me that looking good on the machine and feeling right in my own body are not always the same thing. They are not always the same thing. And for too many people over 60, that gap between the number on the screen and the lived experience of their own body goes unnamed, unexamined, and unaddressed for years." Let me take you deeper into the biology now, because there is a third organ in this story that almost never gets mentioned in blood pressure conversations, and its involvement is both significant and largely invisible until it is not. The kidneys. 2 organs that sit quietly in the back of the abdomen, receiving approximately 20% of every heartbeat's output. The kidneys filter your entire blood volume roughly 30 times a day. They regulate fluid balance, electrolyte levels, and the concentration of waste products that would otherwise accumulate to dangerous levels. And they require pressure. Adequate, sustained blood pressure is not optional for renal function. It is the mechanical force that drives filtration. Without sufficient pressure reaching the glomeruli, the tiny filtration units inside each kidney, filtration slows. Waste products begin to accumulate. Fluid balance shifts, and the kidneys, in response to insufficient perfusion pressure, begin to produce hormones that signal the body to raise blood pressure, which in a patient already on antihypertensives can lead to a complex and often confusing cycle of medication adjustment that treats the symptom without addressing the underlying cause. The insidious quality of renal underperfusion is identical to its cardiac counterpart. It is quiet. A kidney losing filtration efficiency does not send pain signals. It does not produce symptoms in its early stages that a patient can feel and name. It shows up first in blood tests, in a gradual upward creep of creatinine levels, in a slowly declining estimated glomerular filtration rate, in lab values that might prompt a physician to note, kidney function slightly reduced, will monitor, without connecting it to the blood pressure target being aggressively pursued in the same patient. I want to be direct with you about something because I think directness is a form of respect. I am not arguing against blood pressure treatment. I am not suggesting that high blood pressure is acceptable or that the risks of uncontrolled hypertension are exaggerated. Stroke, heart attack, heart failure, renal disease, cognitive decline. These are the real, documented, devastating consequences of blood pressure that is genuinely too high and genuinely unmanaged. I know these consequences. I have seen them. The case for treating hypertension in older adults is strong, and I stand behind it. What I am saying, with equal conviction and equal grounding in the evidence, is that the treatment must be calibrated to the individual body receiving it. That the target must be determined not by the age and physiology of the population on which the original research was conducted, but by the age, the arterial condition, the symptom profile, and the complete clinical picture of the specific human being sitting in the examination chair. And that a measurement taken in a single position, once, in a clinical setting, without any assessment of what happens when that person stands up, is an incomplete picture that can lead to consequences as real and as serious as undertreated hypertension. This brings me to the brain and to a conversation that is perhaps the most important one in this entire discussion, because the stakes are permanent in a way that blood pressure readings are not. Research conducted across multiple large longitudinal studies has established a direct and documented relationship between arterial stiffness, reduced cerebral blood flow, and progressive cognitive decline. The brain is an extraordinarily demanding organ. It represents approximately 2% of body weight and consumes roughly 20% of the body's entire oxygen supply. It has no meaningful reserve capacity. Unlike muscles, which can function in a low oxygen state for short periods by switching to anaerobic metabolism, the brain cannot. When blood flow to the brain diminishes, even modestly, even transiently, function diminishes with it. Not always dramatically, often subtly, but cumulatively. The small vessels of the brain, the white matter tracts that carry signals between regions, are particularly vulnerable to prolonged periods of reduced perfusion. When they are chronically underperfused, they deteriorate. The medical term is white matter hyperintensities. On brain imaging, they appear as small, bright spots scattered through the white matter, and their presence and density correlate directly with cognitive performance. More lesions, slower processing. More lesions, weaker executive function. More lesions, less reliable memory. And they accumulate silently, over years, without any single identifiable moment at which something goes obviously wrong. What is the relationship to blood pressure management? When a patient over 60 with stiffening arteries and naturally declining diastolic pressure is placed on an aggressive antihypertensive regimen that pushes their pressure below the threshold, their cerebral circulation can safely tolerate. The brain's small vessels receive less blood, less consistently, over time. The accumulation of white matter damage accelerates. The cognitive decline that follows is attributed, in the absence of any other identifiable cause, to age. It is labeled age-related cognitive decline. It goes into the chart as expected aging. And in some cases it is. But in a meaningful, measurable, and in some patients partially reversible portion of cases, it is vascular in origin. And a portion of that vascular origin is blood pressure that was managed according to a target that was wrong for that body. I want to sit with that for a moment without amplifying it into alarm, because alarm is not what I am offering you. What I am offering is clarity. If you have noticed that your thinking is slower than it was 3 years ago, if words come a little less quickly, if you find yourself losing the thread of a conversation in a way that is new, if you feel mentally foggier than your baseline, these experiences are worth bringing to your physician, not simply as complaints about aging, but as potential cardiovascular signals. They deserve investigation. They deserve the 3-minute lying to standing blood pressure test that most patients over 60 have never received. Now let us talk about falls. Because in the context of aging and blood pressure management, falls are not a minor inconvenience or an embarrassing mishap. They are a medical event with consequences that can be life-altering and, in older adults, life-shortening. Orthostatic hypotension, the drop in blood pressure upon standing that I described in Emil's case, is associated in research involving tens of thousands of older adults with a dramatically elevated risk of falls. The numbers are not subtle. A fall in an adult over 60 carries risks that escalate sharply with age. Hip fractures, the most common serious consequence of falls in this age group, are associated in multiple studies with a significantly elevated risk of death in the year following the fracture. Not from the fracture itself necessarily, but from the cascade of complications that a serious fall initiates in an older body. Immobility, pneumonia, deep vein thrombosis, surgical complications, the interaction of anesthesia and existing medications. A fall that seems like a single event is, in the biology of aging, often the beginning of a very serious clinical trajectory. And yet, orthostatic hypotension is one of the most underdiagnosed conditions in older adults. Not because it is rare. Research suggests it affects between 10 and 30% of adults over 60, with that proportion rising significantly with age, but because detecting it requires a test that almost never gets performed in a standard appointment. The test is simple. The patient lies flat for 5 minutes. Blood pressure is measured. The patient stands. Blood pressure is measured again immediately and then again after 2 minutes of standing. A drop of 20 or more points in systolic pressure constitutes the clinical diagnosis of orthostatic hypotension. 3 minutes of clinical time. Information that changes everything about how a patient's blood pressure medication is managed, and it is performed in a vanishingly small proportion of routine blood pressure appointments. I want to ask you something direct, and I want you to think about it honestly. When was the last time your doctor measured your blood pressure in 2 positions in the same appointment? When was the last time they had you lie flat, checked your reading, then stood you up and checked again? If the answer is never, you are not unusual. You are in the majority of older adults receiving blood pressure care. And that majority deserves to know that the information missing from their routine care is not trivial detail. It is clinically significant data that could be changing the decisions made about their treatment. There is also a medication dimension to this conversation that requires honest attention. Antihypertensive medications do not work in isolation. They are prescribed, adjusted, and reviewed in a system that does not always look comprehensively at everything a patient is taking simultaneously. And the medications most commonly used to manage blood pressure in older adults, diuretics, beta blockers, calcium channel blockers, ACE inhibitors, angiotensin receptor blockers, each carry their own profile of effects on postural blood pressure, on renal perfusion, on cardiac filling pressures, and on cerebral blood flow. Diuretics reduce fluid volume, which lowers blood pressure, but also reduces the blood volume available to maintain adequate perfusion when the patient stands. Beta blockers slow the heart's rate and force of contraction, which means that when postural changes demand a rapid increase in cardiac output to maintain brain perfusion, the medication blunts that compensatory response. Calcium channel blockers relax vessel walls, which is beneficial for blood pressure control but can exacerbate the drop in pressure that occurs upon standing in an already vulnerable patient. And when these medications are combined, which they frequently are in older adults with more complex cardiovascular pictures, the compounding effects on postural blood pressure can be significant in ways that no individual prescriber, looking at a single medication in isolation, is positioned to fully evaluate. This is not a criticism of prescribing physicians. It is a structural reality of how modern medicine manages polypharmacy in older patients. The cardiologist adjusts the antihypertensive. The general practitioner manages the diuretic. The psychiatrist has prescribed a medication for sleep that also has mild antihypertensive properties. Nobody has looked at all 3 together in the context of a 74-year-old body that holds the stairs railing every morning and calls it aging. And until someone does look at all 3 together, while asking the right questions about what happens when this patient stands up, the picture is incomplete. I want to give you something practical now. because information without action is ultimately just weight, and what I want to give you is something you can carry into your very next appointment and use. 3 questions. Write them down. Take them on your phone. Read them aloud if you need to, because these questions could change the quality of your care for years. The first question is this: will you measure my blood pressure lying down and then again immediately upon standing? Ask for it by name. Orthostatic blood pressure measurement. Tell your physician you have been experiencing any dizziness upon standing, any morning fogginess, any unsteadiness that is new or worsening. These symptoms are clinical indications for that test. If you have not experienced those symptoms, ask for the test anyway on the basis that you are over 60 and taking antihypertensive medication, which is itself sufficient clinical justification. This 3-minute test is the single most important piece of information missing from most older adults' blood pressure care. The second question is this: given my age, my arterial health as you understand it, and the symptoms I have described, what blood pressure range is genuinely appropriate for my specific body? Not the population average, not the guideline number that was calibrated on middle-aged adults, the range that accounts for where my arteries are physiologically and that keeps adequate blood flowing to my brain, my heart, and my kidneys without pushing my diastolic pressure below the threshold my system can safely sustain. This question is not a challenge. It is an invitation to individualized medicine, and a well-informed physician will welcome it. If the answer you receive is simply a repetition of the guideline number without any acknowledgement of individual factors, that is information too. It tells you that this particular conversation needs to continue, perhaps with a specialist. The third question is this: could any of my current medications, considered together as a complete list, be contributing to the dizziness, the fogginess, or the unsteadiness I experience? I want to be clear that I am not asking about side effects of any single drug. I am asking about the combined effect of everything I take on my blood pressure when I stand up. This question signals that you understand polypharmacy and that you are asking for a complete review rather than a single drug evaluation. Many patients over 60 are taking 5, 6, 7 medications simultaneously. The interactions between them, particularly their cumulative effects on postural blood pressure, are rarely reviewed comprehensively unless someone specifically asks. 3 questions. 1 appointment. The potential to identify and correct something that may have been quietly affecting your quality of life for months or years. Now I want to talk about what appropriate individualized blood pressure management actually looks like in practice, because I want you to understand the landscape your doctor is navigating, and I want you to feel equipped to be a full participant in that navigation rather than a passive recipient of decisions made without your input. The guidelines that govern blood pressure treatment are population-level documents. They are built on evidence from large clinical trials, and they reflect the best available understanding of what works for most people across broad age categories. For most active, independent adults between 60 and 75, without significant frailty, without falls history, without pronounced arterial stiffness or diastolic instability, the evidence supports treating to a systolic target below 130. The large trials that established this, including studies conducted specifically in older populations, show meaningful reductions in stroke, heart attack, and cardiovascular death at that target in this group. I respect that evidence. I apply it in my practice. But the European Society of Hypertension, which is one of the world's leading bodies in this area, applies age-stratified targets in its guidelines that acknowledge a reality the population-level guidelines sometimes obscure. For adults between 65 and 79, the recommended systolic target range is 130 to 139. For adults over 80, or for anyone of any age who meets criteria for frailty, the acceptable range extends to 140 to 150 systolic. And that higher range is not a concession to inadequate care. It is biology-appropriate medicine. It is the recognition that an arterial system that has changed its fundamental mechanics over decades of aging does not benefit from, and may be harmed by, targets calibrated for a younger system. The diastolic dimension deserves equal attention. A diastolic pressure consistently below 70 in an older adult with documented arterial stiffness and active coronary disease is a signal that warrants reconsideration of the treatment regimen. Not every patient in that situation is being harmed, but every patient in that situation deserves a physician who has looked at the complete picture and made a conscious, informed decision about whether the current target serves this particular individual's biology. That conscious, informed, individual decision is what distinguishes genuinely good medicine from the application of population averages to individual human beings. There is also a timing dimension to blood pressure management that most patients know nothing about, and that has real clinical significance. Blood pressure is not a fixed number. It follows a rhythm across the day and across the night that reflects the autonomic nervous system's activity cycle. Most people's blood pressure is lower during sleep and rises in the early morning hours, driven by the cortisol surge that precedes waking. This morning rise in blood pressure is well documented and is clinically meaningful because it corresponds precisely to the window in which cardiac events are statistically most likely to occur. Some older patients have blood pressure that is well controlled when measured in a clinical setting during the day, but rises significantly during the nighttime hours. This pattern, called non-dipping or reverse dipping, is associated with increased cardiovascular and renal risk, and it cannot be detected with a single daytime office reading. Some patients have the opposite pattern, well controlled during the day but with a morning surge upon waking that briefly drives pressure to concerning levels before normalizing. Others have blood pressure that is adequately controlled lying down but drops dangerously upon standing, a pattern that a sitting-only clinical reading will never reveal. The tool that captures all of this information is ambulatory blood pressure monitoring, a device worn for 24 hours that takes readings automatically at regular intervals through both the waking and sleeping periods, providing a complete picture of how blood pressure actually behaves across a full day and night, in real life, in the patient's own environment. This monitoring is not universally available, not universally covered by all health systems, and not universally offered to patients who might benefit from it. But if you have been experiencing symptoms that suggest your blood pressure management may not be optimally calibrated for your biology, and if your routine office readings do not fully explain those symptoms, ambulatory monitoring is a conversation worth initiating with your physician. Home blood pressure monitoring is a more accessible alternative that provides meaningful additional information. A validated home monitor, used correctly with the arm at heart level, after 5 minutes of quiet sitting, in the morning before medication and in the evening, generates data that a once-yearly office reading simply cannot. And importantly, it allows you to observe patterns that your physician cannot see in the clinic. Is your pressure consistently higher in the morning before your medication? Does it drop significantly on the days you are more active? Does the reading you take immediately after standing feel different from the one you take sitting? These observations are data. They are clinical information. And bringing them to your physician in a consistent, recorded format, as Emil did with his spreadsheet, changes the quality of the conversation you are able to have. I want to spend a moment on something that sits at the intersection of medicine and lived experience, because I think it is where the most important truth of today's conversation lives. Aging changes the body. That is not a medical opinion. That is simply the reality of time passing through a biological system. The arteries stiffen, the autonomic reflexes slow, the renal reserve diminishes, the brain's cerebral autoregulation, its ability to maintain consistent blood flow across a range of systemic pressures, becomes less robust. These changes are real, and acknowledging them is not pessimistic. It is honest. And honesty about what the aging body needs is the foundation on which genuinely protective medicine is built. But there is a profound difference between aging and suffering, between the physiological changes that come with 6 or 7 decades of living and the symptoms that occur when treatment designed for a younger body is applied to an older one without adequate individual calibration. The fog that Emil thought was his mind becoming less reliable. The dizziness that Marguerite's friend accepted as the price of her years. The way someone stops their morning walk not because they have lost the will for it, but because their legs have become uncertain beneath them, and they cannot name why. These are not the inevitable experiences of aging past 60. Some of them are, but many of them are the correctable consequences of a mismatch between a treatment target and a biology. And the fact that they are correctable the fact that addressing that mismatch can return clarity, steadiness, and capacity to someone who had quietly begun to grieve their loss is one of the most important things I know how to offer in my work. You are not supposed to feel like you are disappearing. You are not supposed to accept fog and unsteadiness as the terms of the decade you are in. These are signals, and signals deserve to be read. Let me bring this all together now, clearly and completely, because I want you to leave this conversation not with anxiety, but with a framework. A way of understanding your own blood pressure management that makes you a more informed and more empowered participant in decisions that affect the quality of every single day you live. The 120/80 standard emerged from research in younger middle-aged populations. It is a reasonable starting point for adults who are active, independent, and without significant arterial stiffness or postural symptoms. But it is not universally correct for every person over 60, and applying it without individual calibration in an older body with stiffer arteries and naturally declining diastolic pressure can produce real harm. The J-curve effect is real. Below a certain diastolic threshold, particularly in older adults with existing vascular disease or arterial stiffness, cardiovascular risk does not continue to fall as pressure is lowered. It rises again. The heart muscle, the kidneys, and the brain all require adequate diastolic pressure to function safely. Pushing that pressure too low in a body whose arteries cannot compensate through elastic recoil has consequences that are cumulative, quiet, and often misattributed to age. Orthostatic hypotension affects a very significant minority of older adults on blood pressure medication, and it is almost never detected without a specific two-position measurement that takes 3 minutes and is performed in a small proportion of routine appointments. The symptoms it produces, fogginess, unsteadiness, dizziness on standing, reluctance to be mobile, are frequently normalized as aging when they are in fact correctable cardiovascular signals. The right blood pressure target for you is not a population average. It is a conversation between your complete clinical picture and a physician willing to look at all of it together. It accounts for your age, your arterial condition, your symptom history, your medication interactions, and what happens to your pressure when you stand up. European guidelines already acknowledge age-stratified targets that permit higher systolic ranges in older and frailer adults, not as a compromise, but as an accurate biological response to what aging arteries actually need. Your 3 questions for your next appointment. Request the lying to standing blood pressure measurement by name, ask for a discussion of your individual target rather than the population average, and ask for a complete review of all your medications' combined effect on your postural blood pressure. These questions are your entry point into a higher quality of care. Use them. And tonight, before you close this conversation and go about your day, I want you to do one simple thing. Think about your mornings. Think about whether there is a fog that arrives before your first medication. Think about whether the stairs require the railing in a way that is new. Think about whether you pause before rising from a chair, not because you are unhurried by nature, but because something in your body has learned to hesitate. If any of those things are true, they are not the rent you owe for the years you have lived. They are signals, and now you know what to do with them. Your body is not working against you. It is communicating with you as clearly and as honestly as it knows how. After 60, part of the work of good health is learning to listen to that communication with more attention and more nuance than the 7-minute appointment usually permits. You deserve medicine that listens that carefully. And you deserve to understand your own biology well enough to advocate for it. I am Dr. Sandrine. This is the conversation I wish every patient over 60 could have before the next prescription is written and the next number gets circled in the chart. Take it to your physician, take your questions, take your right to an individualized answer, and take care of the cardiovascular system that has carried you, faithfully and without complaint, through every single day of your extraordinary life.